Everyone, on behalf of the Radiologia Society of Rio de Janeiro and OCAD, I want to welcome and thank everyone for tuning in today for the MSK case presentation series. My name is Aline Serfaty, and I'm here today with my colleague, Dr. Hilary Humans, who coordinates this series with me, as well as our guest speakers, Dr. Diego Lemos, Dr. Adam Singer, and Dr. Sérgio Viana. You'll be hearing a lot from me today, as in addition to moderating, I'm also presenting a case in this session. So before we begin, I want to let you know that the presentations today, like all the previous ones, will be recorded and will be available on demand on the OCAD website and on the YouTube channel of the Radiologia Society of Rio de Janeiro. To have access to a cutting-edge MSK content, including this series and the multidisciplinary lecture MSK series, please consider registering to the OCAD website, which is ocadmsk.com. In addition to this series, OCAD, which stands for One Case a Day, is also a knowledge sharing forum where we post challenging cases on a daily basis and count on each other to help solve these difficult cases. You can follow OCAD on Twitter and the Radiology Society of Rio de Janeiro on Instagram. So back to our presentations, the speakers today will present their cases, and at the end, we will have a Q&A session. If you have questions at any time during the presentations, please just put them in the chat box, and at the end, the speakers will respond to them. Just a reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you for your understanding, and without further ado, I will introduce our first speaker today. We have the pleasure of having here Dr. Sérgio Viana. Dr. Sérgio Viana is a musculoskeletal radiologist based in Brasília, Brazil, and a full member of the Brazilian College of Radiology. He graduated from the Universidade Federal do Piauí in Teresina in 1995 and completed his training in radiology at the Hospital de Base do Distrito Federal in Brasília in 2000. He co-authored the books Diagnóstico por Imagem em Reumatologia and Joint Imaging in Childhood and Adolescence, and Diagnóstico por Imagem da Articulação Pediátrica. His publications also include 5 book chapters and numerous articles published in Brazil and internationally. He has lectured on musculoskeletal imaging as a guest speaker throughout Brazil and is actively involved in continued medical education in the platform Advanced MSK. Sérgio, please share your screen.
Just a second. Can you see my screen?
Yes, I can.
Okay. So, thank you very much, Aline, for your kind introduction. And first of all, thanks for the kind invitation. It's a real pleasure to be here today. So we're gonna discuss the case of a 31-year-old man with fever, weight loss, progressive low back pain, and bilateral paraparesis over the course of 2 months. Here we have sagittal images of CT scan. We can see that there is decreased height of the intervertebral discs of L4, L5, and L5S1. There are also erosions along the corresponding end plates, which are more prominent in L4, L5. And there is also this area of bone destruction along the posterior edge of the vertebral body of L5. These are essentially the same images with soft tissue settings. We can see that the discs are hypodense, L4, L5, and L5S1. There are signs of dissemination, anterior dissemination, and development of prevertebral abscess. There are also signs of posterior dissemination and development of this epidural abscess, which is the cause of the bone destruction we see in L5. And there is also this hypodense right-sided paravertebral mass. The axial images are the best to show the real extent, the true extent of the paraspinal involvement. So we can see the prevertebral abscess presenting heterogeneous enhancement. There is also extension to the right psoas muscle. Compare the right psoas muscle to the left one. We have an enlarged muscle and loss of the fat planes. There is also involvement of the left paravertebral muscles with extension to the corresponding intervertebral foramen and surrounding the emergent root. And an intraspinal component, which is compressing anteriorly the dural sac. This MRI was carried out 4 months later, and the most remarkable thing about it is the lack of progression of bone destruction. It's essentially the same pattern of bone destruction we have seen on CT scan. We can see abscesses inside the discs of L4, L5, and L5S1 with dissemination, anterior dissemination and development of the prevertebral abscess, posterior dissemination and development of the epidural abscess. In addition, there is bone marrow edema affecting predominantly L4 and L5, and also a thin stripe of bone marrow edema along the end plate of S1. And on post-contrast on this post-contrast image, we can see enhancement, diffuse enhancement of the soft tissues and of the inflamed bone. Once again, the axial images are the best to depict the real extent of the paraspinal involvement. And we can see that unlike the bone involvement, the osseous involvement, there was progression of the soft tissue component. We can see here we have T2 weighted images, and this one post-contrast T1 weighted images. We can see enlargement of the prevertebral abscess, more prominent intramuscular component inside the right psoas muscle, and heterogeneous enhancement on post-contrast images. The same applies to the intraspinal component, a significant compression of the anterior portion of the dural sac. And the paravertebral component is also more prominent, is now bilateral with extension to the both intervertebral foramina and surrounding the emergent roots. In addition, we can see the development of this fistulous tract communicating the left paravertebral muscles with the skin surface. So let's give these images a thought. We have signs of indolent disease with slow progression, essentially no progression of bone destruction along the course of 4 months with constitutional symptoms. We have destruction of the end plates, which is focal instead of diffuse, and despite the presence of extensive paraspinal disease. We have signs of spondylodiscitis involving more than one disc with anterior and posterior subligamental spread, indicating contiguous dissemination. There is a large and complex soft tissue abscess surrounding the affected vertebra with intraspinal extension and involving the right psoas muscle. These findings are indicative of non-bacterial spondylodiscitis, and by non-bacterial, I mean non-Staphylococcus aureus, which means a low virulence microorganism. And we have to keep in mind that this patient lives in an underdeveloped country such as Brazil, with a high prevalence of endemic infectious diseases such as tuberculosis, which would be high on our differential diagnosis list. But this patient already was diagnosed. His blood tests and the analysis of the pus draining through that fistula were compatible with brucellosis. So brucellosis is an infection caused by bacteria of the genus Brucella. Is an endemic zoonotic disease. In fact, it's the most prevalent zoonotic disease in the world, especially prevalent in developing countries like Brazil. Osteoarticular involvement is one of the most common manifestations, mostly spondylitis, and is more frequently found in the lumbar spine. Clinical and imaging findings are not specific per se, and diagnosis is often challenging. Relevant background is of utmost importance, but we know that it may be absent in up to 30%. This very patient had no relevant history. Such relevant background includes direct or indirect contact with fluids from infected animals, most often livestock, including sheep, goats, pigs, and cattle, and ingestion of food products derived from infected animals, mostly milk and dairy products. And diagnostic confirmation relies on laboratory, mostly blood tests. So from an imaging standpoint, MRI is the most important imaging tool. L3 to L5 is the most affected segment because of its rich blood supply. And abnormalities may affect the vertebrae, the intervertebral discs, and or the paravertebral soft tissues, either alone or in combination. Findings on MRI include bone marrow edema affecting mostly the vertebral bodies, end plate erosions, hyperintensity of the affected disc on tissue-weighted images, decreased disc height, post-gadolinium enhancement of the inflamed tissues. But the thing is that these are non-specific findings, which are common to spondylodiscitis of distinct etiologies. Nevertheless, there are some suggestive findings, some red flags, which may indicate the possibility of Brucella spondylodiscitis. For example, the presence of paraspinal abscesses, which may be prevertebral, paravertebral, and epidural, and involvement of the psoas muscle. These are usually moderate in size, usually more limited than in tuberculosis. Also, the involvement of multiple levels, 2 or more, and the presence of skip lesions indicating non-contiguous involvement is unusual in brucellosis and is common in tuberculosis. Absence of vertebral collapse or morphologic changes is typical of Brucella spondylodiscitis. On the contrary, these are typical findings in tuberculosis. The presence of focal end plate erosions, which have been likened by some authors to Schmoll's nodules, with a slow progression compared to the extensive and diffuse pattern of pyogenic spondylodiscitis, and less prominent than those of spinal tuberculosis. And finally, the rare involvement of the neural arch. This article, for example, states that 81% involve the vertebral body only, against 43% in tuberculosis and 23% in pyogenic spondylodiscitis. So in summary, Brucella should be included in the differential diagnosis of spondylodiscitis, mostly in endemic regions and in patients with a prolonged disease course. Despite the excellence of MRI to depict the spinal involvement, findings are not unique enough to make a specific diagnosis. Nevertheless, there are some red flags, as I said, which include absence of vertebral collapse or deformation in spite of extensive and/or long-standing disease, multi-level disease more common in contiguous vertebrae, focal erosions instead of diffuse, and the presence of paravertebral abscesses and involvement of the psoas muscle. Spinal tuberculosis is the most important differential diagnosis. However, the dorsal segment is the most affected in tuberculosis. The pattern of vertebral destruction is more significant, and the paravertebral abscesses tend to be more extensive, as well as multi-level disease, which may be either contiguous or non-contiguous in tuberculosis. and are typically contiguous in brucellosis. So this is it. These are my social media. It will be a pleasure to get in touch. Thank you very much for your attention.
Thank you, Sérgio. Thank you very much. Beautiful case.
Okay, now I have the pleasure of introducing Adam Singer, who is an assistant professor of radiology at Emory University in Atlanta, Georgia. He is the Musculoskeletal Fellowship Program Director and the MSK Site Director for Grady Memorial Hospital, which is Atlanta's Level 1 Trauma Center. He completed a diagnostic radiology residency at the University of Miami in Florida, followed by an MSK fellowship at Emory University in Atlanta. His primary interests are peripheral nerve and sarcoma imaging. As an aside, Adam and his colleague Felix Gonzalez organized a fabulous radiology lecture series during the height of the pandemic in the United States, which was the inspiration for the current clinical lecture series hosted by OCAD. I admire his passion, intelligence, and commitment to growing our musculoskeletal radiology community. Go ahead, Adam.
And also, I must say that Adam introduced me to you. So if we have an MSK,
Well, that's true. Yes.
series today, Adam helped us.
Thank you for the very kind words and for the opportunity to speak. And I'm glad to see that this lecture series, both of them are thriving. So congratulations to you both. And again, thank you so much for the invitation. And I will proceed. Is my screen showing? Okay. Just want to make sure it's.
Yes, it is.
Okay, perfect. So just have a couple of introductory pictures here. You know, as a musculoskeletal radiologist, depending on where you are, if you're at a site that's doing a lot of orthopedic surgery, spine surgery, you're running into situations with diabetic feet and diabetic ulcers and osteo, you may see yourself using imaging to guide interventions to handle this. So part one is make the diagnosis, and part two for us often is trying to figure out what we're treating. And I don't know how many people are doing ultrasound guided toe biopsies, but this is an area we're exploring right now. So with that, just leading into the case. So let's see. There we go. So the history, this is what we had. I'm adding a little bit onto the requisition here, but essentially leg swelling and pain with concern for infection. And the typical comment that we get is rule out abscess and osteomyelitis.
Please mute your microphone. Se você puder mutar todo mundo, obrigada.
So in our institutions, we've adopted several different protocols to assess for where a source of infection may be occurring. And I'm sure this is similar to other places. We hopefully sometimes are able to sort of nail it down to we're concerned about the thigh, we're concerned about the knee, but sometimes it ends up being scan the entire limb from hip to toe. And that seems to be occurring more and more frequently, especially with CT. Hopefully we get contrast on board that really helps, but sometimes we don't. Occasionally we get requests for full limb MRI, which our techs get really concerned about when we see that. So we try to sort of tailor things, but this is sort of the typical indication. We often see several of these in the next morning from the overnight ER with the residents issuing preliminary reports at our institution on these. So a little bit of additional information that wasn't provided. You have to go into the chart and find this out, but this is a 30-year-old with immune compromise, and he's presenting with swelling of the right leg. The first step that was performed in the ER was a DVT study, and it was negative for thrombus, but they did note these inguinal nodes. You can see these sort of enlarged hypoechoic, lumpy, bumpy lymph nodes, marked increased vascularity in them. Really no discernible fatty hilum. So this is what I was talking about, sort of the typical thing that we see. This is the scout view, and I show the scout to show what we're doing, but also to sort of give a lay of the land as to what's going on. So if you just take a look at the scout, you can see a little bit of information from the scout, and then I'm going to go through a couple of the cuts on the diagnostic CT part. So I'm just going to scroll through here, and I apologize, it's jumping. I didn't do the whole stack because it would just take forever. But scrolling through, fortunately, we did have contrast on board for this exam. Coming through. All right, and so a lot of the time, this is sort of what the preliminary report is, and this was what happened in this case. You know, we went on our search and destroy mission for abscess and osteomyelitis or septic arthritis, none of which was seen there. And so we were left with a preliminary report such as this, and to follow up the next day. So as one of my attendings used to say back in residency, what do we have? So the first thing we have is lymphadenopathy in the inguinal region. And then the second thing is diffuse unilateral subcutaneous edema, worse in the thigh than in the calf. And so if we back up for a second and go back to the scout, I just want to point this out again, because I think the scout often can give a lot of information that may not be as obvious when you're scrolling through, especially if you cut off parts on the diagnostics. You can see you barely catch the medial side of the unaffected limb. But if you compare the soft tissues here, you can see that there's a marked difference in girth of the affected thigh compared to the non-affected thigh. So now coming back through here. We'll start with the first part here. So the lymphadenopathy. So we have multiple enlarged lymph nodes as we're coming through here. And they are enhancing similar to the adjacent vessels here. So a little bit of an unusual appearance there. And then as we come through, we see skin thickening. And if you look really carefully, you can see these little nodules here and here. And they're really up and down. I don't have the stack here, but as you scroll up and down, you see several of these. And I'm going to blow these up. We go further down. And then things normalize a little bit as you're going down. So now sort of blown up here. So we have lymphadenopathy enhancing similar to vessels. So we've got some hypervascular lymphadenopathy, hyperenhancing, and then diffuse unilateral subcutaneous edema and skin thickening in the thigh. And then you have these nodules in the skin, and some of them are also enhancing similar to the node. So you can again see these little nodules here. So here, and then some smaller ones as you're going through here. So there was a differential that we were coming up with, and a lot of this was based on the hypervascular nodes and then noticing the other findings. So things we were thinking about, yes, this could be infection, opportunistic infection, but other things, hypervascular nodal metastases would be a possibility. Castleman disease, Kaposi sarcoma, lymphoma, related to HIV infection, if that was what was the case, angiosarcoma, and bacillar angiomatosis. So these were the things that we were thinking about. And so we needed to do a chart biopsy. And so we ended up doing a chart biopsy, which often helps us. And we were able to speak with some of our colleagues. So these are the dermatologists who assessed this patient after he was admitted. And you really can see here to a better advantage when you're looking at the patient. It's not as subtle as on the CT and on the scout, but there's a marked difference in the girth. And you can see this rash on the skin here. So thank you to Dr. Chile and Rogers for this information and these images. And if you look at the images they provided, you can see this maculopapular rash really in the area where we were seeing some of these skin nodules on the CT scan. So we continued our chart biopsy, and the patient was HIV positive. At the time, his CD4 count was 835 and was on heart viral load, as you can see. And he reported progressive right lower extremity swelling over a 3-month period with developing rash. And per the dermatologist, there was a tender coalescing purple papules and plaques. Smaller ones were starting to form on the other leg as well. So a biopsy was performed, and thank you to the pathologist, Dr. Parker, who provided us with these slides and this interpretation. I won't pretend that I'm a pathologist. This is just what he gave us and gave as a description. Low magnification and high magnification showing neoplastic cells, displaying ovoid and spindle features with admixed small vascular channels. And so he said this was basically diagnostic for Kaposi sarcoma. So I have a couple of companion cases here, and so I'm gonna move the Zoom thing out of the way for me. This was a 29-year-old with HIV. It was a new diagnosis with a CD4 count of 220. And again, we see these hypervascular lymph nodes. In this case, there were some areas of central low attenuation. Similar findings actually in the head and neck. I just gave a representative image so you could see, but this was involving all nodal levels. And then again, on the ultrasound, this ill-defined enlarged conglomerate of lymph nodes with vascularity similar to the adjacent vessels. Another companion case. So this was again unilateral swelling. The DVT study was performed and it was negative, and they noted a small lesion over on the skin on the the medial side of the left leg, on the PET and lymphadenopathy. And so this was biopsied here, and this was Kaposi sarcoma with nodal involvement. So it's good the order that we selected in terms of who's presenting today. Diego and colleagues wrote this paper for the imaging manifestations of Kaposi sarcoma. It's an excellent paper to read if ever you have interest in learning more about this. But they did an excellent job here. And just to touch on some of the key findings and things to know about this. So there are 4 variants that are described. Classic, the Mediterranean endemic, which is the African, associated with immunosuppression. And this is going to be usually in the setting of transplants, organ transplants, and then an epidemic, which is HIV associated. The human herpes virus 8 is associated with the Kaposi sarcoma, and the epidemic Kaposi sarcoma, like many of the other variants, can have involvement of multiple areas, but it's a neoplasm arising in the lymphatics, and so you often see it in the skin and the oral mucosa, but you can see it in organs as well. Gastrointestinal tract is known to be involved, as is lung and liver. So multiple areas to think about, and then obviously lymph nodes, as you've seen here, and the lower extremities are frequently involved. Multiple lesions usually present, and as I mentioned, you can see them externally, or they may be seen on our scans, our cross-sectional scans with internal organ involvement. And the HIV related can be more aggressive than some of the other variants. The MSK manifestations are often from the infiltration by the skin lesions, and rarely there have been reports of bony erosion as a result of infiltration from soft tissue and skin masses, but it is said to be rare. The typical swelling that you may see that makes people think about the possibility of a DVT would be in part because of the lymphatic involvement, plugging up the lymphatics, scarring them down. So this is a typical presentation. As you saw from one of the companion cases, they're often hypervascular, and so it invokes that hyperdense and hypervascular differential for the nodes, but you can have central hypodensity as well. But you also want to be aware that this patient is also at risk for non-Hodgkin's lymphoma, so that would be why you would think about this in your differential. Unilateral limb swelling in Kaposi sarcoma may be due to this lymph system involvement, as I just mentioned. You want to look for the manifestations outside of the skin. So the skin may just be the tip of the iceberg. For people studying for boards, there are nuclear medicine scans that sometimes come up on tests. So the thallium will be hot on for Kaposi sarcoma and lymphoma, while the gallium is going to be negative in Kaposi's typically, but positive in lymphoma and infection. Bacillary angiomatosis caused by Bartonella is a non-neoplastic mimic of Kaposi sarcoma, and also may be seen in the HIV positive population. So the key points that I just wanted to take home from this: don't stop your search as soon as you exclude abscess and osteomyelitis, and default to something like could be cellulitis in the appropriate clinical setting, volume overload, venous stasis, etc. So look carefully. If you need to get some clinical information, it may help you make this diagnosis. Unilateral leg edema in an HIV positive patient and no DVT, you want to consider this diagnosis and carefully look for skin nodules. Hyperenhancing lymph nodes are seen in several scenarios, but KS is one of them and should be in your differential up at the top if the patient is HIV positive. And then lymphoma, Castleman disease, bacillus angiomatosis should also be considered in this patient population. And that is it.
Thank you, Adam. So now I'm introducing Diego Lemos. Diego Lemos completed medical school in the Universidade Libre de Cali. I hope my Spanish is good, I don't know.
That was perfect.
In Colombia, his country of origin. After that, he moved to the United States and started his radiology residency training at Louisiana State University of New Orleans in Louisiana. After Hurricane Katrina, Dr. Lemos transferred and finished his radiology residency at the University of Vermont Medical Center in Burlington, Vermont. Upon completion of his residency, he did a formal one-year fellowship in musculoskeletal radiology at the University of California in San Diego with Dr. Donald Resnick and the UCSD group. Upon completion of his fellowship, Dr. Lemos returned to UVM Medical Center, where he's been the division chief of musculoskeletal radiology since 2009. Dr. Lemos has published more than 20 articles and 4 book chapters. He has presented more than 50 posters and electronic exhibits in different meetings of the specialty and subspecialty. Dr. Lemos has dictated more than 80 conferences nationally and internationally inside and outside the United States. He's an active academic MSK radiologist in social media, including Twitter and Instagram. Please, Diego, share your screen.
Okay. Can you guys see the screen now?
Yes.
Okay. So over the next, thank you, Aline, for the introduction and for the invitation to participate on this activity. Over the next 10 minutes or so, we're going to discuss an interesting case that we had about 3 years ago or so at UVM. He was a 12-year-old kid with approximately 3-year history of intermittent traumatic right thigh pain. This pain was somewhat cyclic in nature. The symptoms will come and go and will spontaneously resolve. He complained that he had intermittent subjective fevers, but they were never truly documented. He didn't complain of any other pains, and there was no weight loss. The inflammatory markers upon consult were mildly elevated, including the sedimentation rate and the CRP. The white blood cell count was within normal limits, and they drew blood cultures, which were pending. And then they ordered a battery of imaging studies. The kid actually came with outside radiographs from outside institution. So I'm showing you here frontal and forelegal views of the hip. Actually, the femur, they split the image in two. So here is the lower half of the femur, and here is the upper half. And you can see that there is this very interesting fusiform area of cortical thickening centered on the right femoral diaphysis, with quite striking narrowing of the medullary cavity. And if you pay close attention, you can see that there is some thin periosteal reaction. So those were the X-rays, and there were no prior studies at the time. So this was overnight. So the CT got ordered, which I'm showing you here, the coronal to the reformation. which shows again the same findings that on the X-ray. Notice again the narrowing of the medullary canal in the mid diaphysis, and here are some 4 axial representative images, proximal and at the level here about the proximal diaphysis where the medullary encroachment was the most, and here distally towards the knee. So a bone scan was subsequently ordered. This was like 3 or 4 days after the kid was admitted, and and it was further worked up. So the whole body bone scan shows findings that correlate with the radiograph and with the CT, with increased radiotracer uptake centered on the femoral diaphysis, which appears to taper toward the edges of the long bone. And there were no other lesions. The reason why the whole body bone scan was pursued was to determine if we were dealing with a monostatic or with a polyostatic process. And there was no evidence of increased radiotracer uptake elsewhere. So we were dealing with a monostatic condition at this time. Here are the MR images, coronal T1 non-FATSAT, coronal STIR, and coronal T1 FATSAT after intravenous conscious administration. And right away, you can see that there is soft tissue edema and enhancement in the anterior soft tissues of the thigh. And as we get towards the femur, you can see that the same findings on the X-ray, the CT, and the bone scan translate very nicely on this MRI and the T1 weighted images. You can see the tremendous cortical thickening and the narrowing of the medullary cavity center on the diaphysis. And then you can see that there is bone marrow edema and periostitis, which show enhancement after contrast administration. So let me show you a few of the axial images. So you can appreciate here the striking periostitis and the cortical thickening and the enhancement of the periostitis, which is non-specific, but certainly we didn't see an associated soft tissue mass. So these were the most representative images that I just wanted to share, and distally came back to normal. So all these imaging studies, what they show was kind of an aggressive looking diaphyseal lesion in the right femur without a discrete soft tissue mass. And it was a monostatic process. And the kid had this 3-year history of waxing and waning symptoms and some subjective fevers, not really weight loss. So at the time, the differential diagnosis that was suggested certainly include osteomyelitis, but e.g. eosinophilic granuloma was in the differential, as well as more ominous conditions, neoplastic ones, such as Ewing sarcoma, osteosarcoma less likely, but still in the differential, and most certainly a lymphoproliferative process, such as lymphoma, was also included in the differential. So tissue sampling was necessary for a more definite diagnosis and to proceed with further treatment and recommendations. So a biopsy was scheduled, and here there are some images of the biopsy, the fluoroscopic images, and then the follow-up radiographs. The lesion did not disappear, like sometimes you see with some of the legends and cell histories of the EGs that can become less conspicuous after biopsy, actually, because the reparative process, this was quite of an extensive and long segment lesion of long tubular bone. So the final pathology, and I apologize, the pathologist wasn't able to send me the images on time. The final pathology was actually consistent with reactive moving bone and chronic inflammation. There were some foci of subacute inflammation, but it was mostly chronic, and there was certainly no evidence of malignancy. The microbiology, including bone, including blood, and the biopsy bone and soft tissues, all came back negative for organisms. So the correlating the pathology with the clinical history, the labs, and the imaging studies, the diagnosis that was proposed was a non-bacterial osteitis. This was in conjunction with the orthopedist, the pediatric orthopedist, and the oncologist and the rheumatologist. We discussed the case at multidisciplinary conference. And the patient was studied, the kid was studied actually on indomethacin, BI twice a day. And he was very well controlled with this. There were some periods of time where he will stop taking the NSAID, and then he will have a flare of the condition. But as long as he was sticking to the treatment, he was pretty well controlled up to 3 years after the initial diagnosis. And that's where we are right now. So it was not a case of osteomyelitis. It was, if you will, a non-infectious osteitis or non-bacterial osteitis. So we felt pretty good about ourselves. It was kind of a diagnosis of exclusion, but we did all the workup that it was necessary. And when you go and look at the literature, I apologize for this slide. I know it's busy, but it's just to show that there is a plethora of names that have been used for this condition, from MBO, from non-bacterial osteitis to non-bacterial osteomyelitis, non-bacterial chronic non-bacterial osteitis, chronic non-infectious osteomyelitis, sclerosing, chronic sclerosing osteitis. So, you know, when you have a lot of names for one condition, there are some issues there. But certainly the final diagnosis, and that's how he was worked up and followed up, was that of non-bacterial osteitis. Non-bacterial osteitis is a non-infectious inflammatory lesion of bone. It's more of a descriptive or an umbrella term that refers certainly to a sterile skeletal lesion with non-specific histological signs of inflammation. Some people, some researchers use interchangeably the terms non-bacterial osteitis or non-bacterial osteomyelitis with chronic sclerosing osteomyelitis. Some of the old literature will refer to the sclerosing osteomyelitis of Garay. This condition has been reported in virtually all bones and may be either monostatic or polystatic. It can be acute, subacute, or chronic in nature, and it can recur. So it primarily occurs in children and adolescents. The peak of onset is around 7 to 12 years of age, and the incidence is anything between 0.4 and 10 per 100,000 individuals, and the female-male ratio is between 1 to 4 females per 1 male. Currently, non-bacterial osteitis is a diagnosis of exclusion, is based on imaging and pathologic diagnosis. The pathology, the histology reveals acute and chronic inflammatory infiltrates as well as reparative bone features, and there is no isolation of an infectious agent. So there is an overlapping of terms here, but what the current thinking is that probably non-bacterial osteitis together with CRMO, with chronic relapsing multifocal osteomyelitis, as well as with SAFA syndrome, probably are part of the spectrum of the same condition. And only they suggest that only when the condition is truly chronic and recurrent and multifocal, it's probably better to use the term CRMO. But if not, probably MBO is on the early, on the more mild part of the spectrum, with CRMO and SAFA corresponding to the other end, most complex end of the disease. The pathogenesis of non-bacterial osteitis is unknown, but it's currently classified as an autoinflammatory disorder. So I just want to show in the last 30 seconds this article from AJR 2009 of chronic sclerosing osteitis, or MBO, involving the diaphysis of the tubular bones, just to show you the similarity with our case. The bone, the femur is one of the most common long tubular bones involved on this process, and you can see that the X-rays as well as the MRI and the CT are very similar to the case that I just shared with you. So that's all I have. It's 11 minutes. So I thank you all for your attention.
Thank you, Diego. Thank you very much. Beautiful case.
Thank you.
Actually, Sérgio presented a case like that in one of our image group meetings.
Oh, that's great.
Yeah.
Yes, it was more like a CRMO.
CRMO.
Patient, yes, but it was very interesting because it was there was no involvement of the skeletal, of the peripheral skeletal. Only the spine, the ribs, and the sternal. Sorry,
Sternal joint.
the costovertebral joint.
Yeah, this case was monostatic, and there was no recurrence after treatment, and because it was only on one bone, the decision was to name it more like MBO rather than CRMO, but I think are part within the spectrum of the disease.
Yes, quite a rich case, very beautiful.
Thank you.
Now it's my turn to introduce Aline Serfaty, who is a practicing radiologist and medical director at MedScan Lagos. She's currently actually, this is hot off the press. Great news. Dr. Serfaty actually was just successfully defended her PhD thesis. So now we should call her Dr. Serfaty. She is an advisory board member at Medscape and also a member of several radiology societies in Brazil and a member of the International Skeletal Society. She's authored and co-authored original research and book chapters in musculoskeletal radiology. Since 2019, she's one of the coordinators of this group, helping to bring education and partnerships among Brazilian and international radiologists. Dr. Serfaty is a moving force behind this current collaboration between the Musculoskeletal Image Group of Rio de Janeiro and OCAD, thanks to the introduction by Adam Singer, and for promoting OCAD among Brazilian radiologists who represent a major and rapidly growing part of the OCAD membership. Okay, I'm looking forward to hearing what you have to say.
Oh, what a responsibility. Say something after those three. Okay. Do you see my screen?
Yes.
Okay. Okay, so my patient is a 48-year-old male presenting with mild back pain radiating to the left posterior thigh, leg, and foot for 2 weeks. The pain gradually became severe a few days after the initiation of symptoms. Past medical history, the patient was diagnosed with COVID 2 weeks prior to the beginning of symptoms, having been treated at home with I can't say that in English, but I'll try azithromycin, maybe, and dexamethasone. And physical examinations, he had a sensory deficit in the left leg and no motor deficit. Oops, sorry. Laboratory findings, there was normal blood cell count, normal CRP, normal serum glucose, and he was HIV negative. And this is not related to the case, but directly related to the presentation. But I think this is interesting to know the treatment that was given to this patient and the treatments that are commonly being given to COVID patients in Brazil, which are contrary to the recommendations of NIH. So back to our case. The referring physician for this patient ordered a lumbar spine MRI, MRI of the sacroiliac joints and of both hips. So the MRI of the SI joints was unremarkable, except for mild muscle edema of the paraspinal left muscles, as you see here in the axial stir images, and also in these coronal stir images. The lumbar spine MRI showed some degenerative discal changes in the lower thoracic levels and from L3, L4 to L5, S1, and perhaps a subtle thickening of L4 nerve root. MRI of the hips MRI was unremarkable. And also the patient was ordered pelvic CT. However, no bone changes were observed except some sclerosis in the lumbar low end plates. So at this point, I was very curious because the patient reported severe pain and all I was seeing was degenerative changes and left parvospinal muscle edema. So I called the referral physician and to see if I could get any more information on this case, but he could not provide me more details about the patient history, nor what he was thinking, because the patient is a military pilot and he's not allowed, so the physician is not allowed to provide any info on the case. So I called the patient and he ended up returning to the clinic and then we had a chance to talk. As he was telling me his story, I noticed some changes in the skin, in the skin of the left thigh and leg. So this day, the patient underwent MRI neurography of the lumbar plexus, and this is what I saw. So DWI showed hyperintensity of the left femoral and obturator nerve. As you can see, all along the psoas muscle. And okay, so in yellow is the normal side and blue is the where you can see the hyperintensity. And the other DWI images show a hyperintensity of the femoral nerve along the psoas muscle all the way of this nerve, as you can see here. And coronal stir images depicts hyperintensity of the left sciatic nerve and also left parvospinal muscle edema. And T1 weighted images shows slight thickening of the sciatic nerve. So yellow normal, blue not normal. And in this coronal stir image, you can see the left femoral nerve and the hyperintensity of the left femoral nerve and the muscle edema of the left rectus femoris muscle. Okay, so this is a fat-suppressed T1 weighted image showing contrast enhancement of the nerve root and adjacent muscle. So in summary, this is a 48-year-old male presenting with mild back pain radiating to the left posterior thigh, leg, and foot for 2 weeks. Neurography, let me put it here, okay. MRI neurography, what we saw was increased femoral obturator and sciatic nerve signal intensity on STIR and DW images. And also edema of the left parvospinal muscles and of the left rectus femoris and nerve and muscle enhancement as well. So we thought about what we saw was an asymmetric lumbosacral plexopathy which has numerous differential diagnoses. But what I didn't show you and what I want to show you is that these were the lesions that I saw when he came to the clinic to do the MR neurography. So the patient had cutaneous vesicular eruption in the chest, thigh, lateral and inferior leg. And some of them were crusted. So we thought about infection and herpes zoster infection. He had a lumbar puncture, and the CSF was clear, but there was, the PCR showed varicella zoster virus DNA, and the cerebrospinal fluid serological testing showed varicella zoster immunoglobulin. So varicella, primary infection with varicella zoster virus causes varicella, which usually is harmless in healthy children. And varicella zoster virus establishes latency in ganglionic neurons and reactivation of viral replication and spread of the virus to the skin innervated by these neurons causes zoster. So there's a segmental pain in the limb affected by herpes zoster. Zoster is caused by varicella zoster. After initial infection, the virus established latency in the sensory ganglia, and the latent virus has the potential to reactivate later in the segmental cutaneous eruption. The most common complication of zoster is post-herpetic neuralgia. And this patient has, now I called him this week, the week before I was presenting this case, and it's been 5 months and he's still in pain. And the spectrum of MR imaging findings may vary from normal to increased signal in the nerve enlargement, and denervation changes in the muscles innervated by the affected nerve. So what we should see in MR neurography, normal peripheral nerves are symmetrical in terms of size, morphological characteristics, and signal intensity. We didn't have that. The skeletal muscles are evaluated for denervation changes, which are, as a rule, always distal to the level of the peripheral nerve insult. And the fascicular pattern of peripheral nerve is consistently visualized in large nerve branches, those with a diameter larger than 3 millimeters, such as the femoral and sciatic nerves. So key points from this case, the diagnostic evaluation of patients with pain and paresthesia referable to the low back and pelvis is complex and should be patient-specific. Lumbosacral plexus MRI provides excellent anatomic detail and contrast resolution with detailed localization and characterization of lesions. So thank you very much. This is my Twitter account, and I'm on Instagram as MSK cases, msk.cases. Thank you. I see some questions here. Okay, this is from Rocky Balboa. Should TB spondylodiscitis always be included in the differential diagnosis of brucellosis and vice versa? I think this one is for you, Sérgio.
Yes, we have some famous people in the audience today, Rocky Balboa. Yes, especially in Brazil, brucellosis is quite a sporadic occurrence. Most of my colleagues have one case or no case during the entire career. It would be interesting to hear from, I've seen Dr. Barus on the audience and Dr. Because articles say that this is an endemic disease in South America. In Brazil, this is not the case. I'm pretty sure that Aline has no experience, no large experience at least with brucellosis, and Sorry, can you hear me?
Yes, I can.
And I'll take from where I was. There was something on my screen. So in most cases, we will have tuberculosis in Brazil. Brucellosis is quite sporadic, and we do not have a large experience. It would be interesting to hear from Dr. Barros from Argentina and Dr. Pablo Rengifo from Peru, their experience, because it's not really common in Brazil. So in Brazil, the first hypothesis for this case would be indeed tuberculosis. Brucellosis is diagnosis of exclusion, even in underdeveloped countries such as Brazil.
Actually, in the first MSK case, the first one, when we kick off the session back in October, I presented a case of tuberculosis, which I remember. Do you remember, Sérgio? I think I shared with you. And then when you told me you were going to present the brucellosis case, I was like, okay, but how many have you saw in your career? And you told me that it was 2. And I said, I only saw it in the books. I have never seen brucellosis here. And I'm Brazilian.
So most articles say that it's endemic in South America. And Brazil is half of South America. But yeah. Most colleagues have seen 1 case or 2 cases during the entire career. So that in first place, we would think about tuberculosis, and brucellosis would be in the differential.
Okay, if Dr. Barros, if he wants to give his opinion, please open your microphone and tell us what.
Dr. K. Herman is saying that, that it's very rare in Germany, of course, but it's a big issue in Lebanon and surrounding countries. That's what the literature say. It's more common in Mediterranean countries. Most of articles that I've seen, that I've read, come from Turkey and most recently from China.
Interesting. There's another question here from Pablo Rengifo. I have a question for the speakers. Which is your typical MRI protocol for osteomyelitis in upper and lower limbs? Which B values do you prefer? Thank you. Adam, do you wanna tell us your experience? Diego? Sérgio?
I can talk for us. We don't use diffusion really that often unless we have no contrast ordered. And even then we often still don't. You know, we did a study looking at least for pedal osteomyelitis, can we get away in many cases with doing a sagittal T1 without fat sat and a sagittal stir to sort of fight failed fat sat with the PDs and T2 fat sats. And we were pretty accurate compared to our full protocol. So, you know, I think for us, you know, standard stir and T1s are usually sufficient for looking for osteo. It's always helpful, obviously, when they put contrast on to look for soft tissue findings to help us feel more confident and to look for, you know, small abscesses and things like that. But that's pretty much what we do.
Same here at the University of Vermont. We have pretty much the same protocol as Adam was saying. Even in patients with a renal impairment, we will prefer MRI than the CT or nuclear medicine. And one thing that I did forget to mention is that now, the same way as we're using whole body MR imaging for assessment of multiostatic processes, such as follow-ups in patients with large cell histiocytosis, or in patients with multiple myeloma, or even for non-accidental trauma on skeletally mature patients. There are several papers in the literature suggesting the use of whole body MR imaging for CRMO and for MBO and for these cases, rather than a whole body bone scan. So, but yeah, but in terms of protocol, we don't use a diffusion weighted imaging either at UDN.
Essentially agree with Dr. Singer and Dr. Lemos. I would only add for CRMO, when it comes to involve the clavicle, I find very useful to perform a CT scan. It allows to depict the findings more properly in several times. So in addition to MRI, when the clavicle is involved, I perform a CT scan. But otherwise, nothing to add to the other speakers.
Okay, I'm searching for questions here.
We have a reply from Dr. Barus about brucellosis.
Yeah. So we have seen few cases of brucellosis here in our, Dr. Barus, yeah. Here in Argentina, TB is very common, and we always think of it when we see a perivertebral abscess with joint disc and vertebra. I have not seen brucellosis, and it has been a long time since we have seen TB. I remember at the beginning of my residency, seeing cases in public hospitals in my country. So I feel better now that he didn't see it too. It's not only me that haven't seen brucellosis. Okay.
Marcelo Bordalo, Dr. Marcelo Bordalo says that in their services, they have seen brucellosis in a rate of 3 or 4 cases per year.
Okay, but Dr. Marcelo Bordalo works in HC USP, so he sees everything 3 or 4 times a month.
Probably the biggest hospital in Brazil.
Thank you, Marcelo. It's the biggest hospital in Brazil, so of course. Dr. Diego, even in chronic osteomyelitis, we find chronic inflammatory cells in histopath. Are NBO and chronic OM similar pathologies? I don't know if it's a question. It's from Rocky Balboa. But I think Diego has a meeting he has to leave. He has another conference right now, so I'm not sure if he's here yet. Okay, so everybody's saying congratulations to all speakers, great cases, fabulous presentations. Thank you so much for tuning in today with us, and see you next month. Next month, our focus is on rheumatology. So we see you next month. Bye-bye. Thank you.
One sector.